Good to go? Do you want to
Let's go.
intro?
Yep. Okay, so we're going to start the lunchtime lecture. I'm going to introduce Dr. Ponraj Tanuduray. He is a research scientist here at Houston Methodist, but he works for Siemens. We actually are the biggest Siemens install in the world. And so right down below you is what's called the Siemens Translational Imaging Center, which has got a 7 Tesla magnet in it. A lot of their research scientists based here. But he works with us on a daily basis doing complex cases. And what we've asked him to do is to talk to you about some of the basics of interpreting a CT scan. Well, we showed you that the other day. This is going to be a little bit more sophisticated than what we showed you. So, Ponraj.
Okay, thank you, Dr. Lunsford. Good afternoon, everyone. Can you hear me well? All the way in the back? Yeah. Awesome. As Dr. Lunsford mentioned, I am one of the research scientists here. I see imaging not from a radiologist standpoint, I see imaging from a surgeon standpoint. So I'm not a trained radiologist, so it's not going to be one of those basic imaging physics radiology lecture. It's going to be, I'll try to keep it interactive. So some of the things I wanted to touch up is very basics of CT. So we're going to limit ourselves to the scope of only CT image review and how do we optimize it and how we plan for some basic vascular procedures. So here are my disclosures. And I would like to kick off with this one of the quote from a historian, from American historian. One of the greatest obstacles, at least from his quote, is into discovery is not ignorance. It's more about the illusion of knowledge, especially when it comes to cross or interdisciplinary skills, such as reading a CT scan or reading an MRI. We often tend to think we do it on a daily basis. Oh, what's the big deal? I look at axial CTs all the time. But we often take certain things for granted. So one of the things I wanted to touch upon today is to how is the concept behind some of these imaging tools are and how we can make use of that in our day-to-day clinical image review. So I kind of wanted to approach this in 2 different modules. So later this afternoon, you're going to rotate through in the hybrid operating room where we're going to touch on the hybrid OR and the radiation part of it. But the first part, which is we are going to kind of talk through today during the lunch session here, is how do we do basic CT review and interpretation. Along that same vein, if I may interrupt your lunch and have you pull up your phone on your left hand, I know you guys can multitask. I have some questions that I have put together. So this is to see where the baseline is, and hopefully you can fare better in some of these questions at the end of this talk. So these are just 10 questions. The game pin will load up in a couple of seconds. I want you to attend as much as you can. We'll run this through quickly. There are some images in here. I will take my time explaining them when we come and do this question at the end of the talk. I hope you should. You don't have to download the app. All you have to do is www.kahoot.it. And it'll ask for a pop-up where you can enter this 7-digit code, and then you're good to go. So we have 2 attendees. So maybe while people are joining, if as a resident or a intern, when you look at the CT images, what are some of your common challenges with the CT? Any thoughts? What do you struggle the most? Or you think? Hopefully I'll answer that question towards the end of these 10 questions. So we got 21. How many total we have? Total 38? Okay. Okay. Any more last? I see Dr. Hyde here. Okay, let's get started. We have 30. Okay. So the first question out of the 10, oh, it is a double pointer. Which one of the following CT values are correct? Nine, 7, 6. Okay, last couple of seconds. Okay, cool. Most of you got it right. Hopefully, we'll get through some more of these questions. So in CT terminology, when you look at some of these images, you see WL and WW in most of these images. So what do those mean? Okay, last second. Good, most of you got it right, 19. So Jason is on the lead. Let's see. So in a CT data with thicker slice, often we get referral CTs with 5mm cuts or 10mm cuts. What is the downside to those thicker slices? Okay, we still have some people saying false, which is, we'll get to those in a second. Okay. So the 3D imaging that we can perform using this mobile C-arm or even a fixed C-arm in a hybrid OR is referred to as yes, it's timed. Okay, most of you got it right. So I'll explain some of these questions towards the end when we come back to it. JC is on the lead. So the following technique is one of the most accurate used for accurately measuring the neck diameter. This is a non-contrast CT just for demonstration, but usually it's contrast enhanced. So how do we get a most accurate measurement? Diameter, perimeter, go to the coronal plane or do your diameter measurement in MPRs. Okay, that's good. Mixed response here. Okay, we are past halfway. So which one of the following stents, so this is an MRI question, caused the most severe artifact or signal distortion in MRI? So this is actually from one of our cases. You see the big, huge signal ward, so usually it's from stainless steel. So the following technique is used for better visualizing smaller structures in CT. So in this particular case, the distal terminal renal arterioles or renal vasculature. Cruel? Okay, good. Majority got it right. Carol's on the lead. Last 2 questions, or 3 questions. So the following rendering mode is best used for visualizing air, for example, in cases with airway compression or bronchial obstruction and stuff like that. So what is the technique typically is used? Okay, most of you got it right. Second last question, which of the contrast agent that is used in imaging is least nephrotoxic? Okay, so we have a mixed response here as well, non-ionic, but this includes MRI as well. So this is an ion-based contrast agent. We'll touch it in our session. Last question. All of the statements are correct except okay, so it's a mixed answer. Let's see who is the lead. Let's see if Dr. Ait has risen up to the podium.
Where's Claire?
Carol's on second. Who is on one? Claire. Good job. All right, the lunch session is over. We all can go back to the hands-on session. So let me switch to the hospital network so I can access images in PACS. Okay, got it. Okay, so the goal here today in the next few sessions is, even though we are using a specific Siemens tool, so there is nothing Siemens-specific algorithm that I'm talking about here. So the focus here is on the concept, not on the tools. So you can pick the tool, whatever you are comfortable with or whatever you have access to in your hospital or in your PC. So, and this is probably the most important value add I can give that you can take out of this lecture. So one of the go-to reference book I have read when I went through my training is this Physics on Medical Imaging. So this is a great resource, and it is available completely online in an open archive. So you can take a picture. I'm happy to share this through everyone. So you can download this and keep this as your reference for most of your physics reference. And this covers very basic MRI as well, PET and CT. So it's not one of those boring physics books. I really enjoy reading this one. And some of the online training, depending on what system you have access to, there are some online training resources from Siemens. In terms of DICOM viewers, so this is often the question I get from fellows. Okay, I have only access to images in PACS, but when I am doing a case tomorrow, I want to be able to at least look at these images quickly before I come in and scrub in these cases. What are the tools I could use? If you have a Mac, the open source software that I would recommend is Horos. So it's a DICOM viewer. You don't have to pay any penny to download and install this. If you have a PC, there are some, if you Google Single Fast View, which is a Siemens tool, or if you kind of like go through some open source DICOM viewers as well called Radiant, is just one example. But for people who use Mac, which I assume is the majority, I would definitely recommend get your hands on Horos. The earlier you get familiarized with this, by the time you finish your residency, you will be expert at manipulating these images with this. So let's get started. So in the operating room, we are still in this good old day of 2D imaging. What I mean by 2D imaging is 2D angiography, whether it is fluoroscopy or a 2D angio, whether it is a mobile C-arm or a fixed C-arm. The biggest challenge here is you have a 2D projection image. For example, in a complex structure like this, we have no idea which one is anterior, which one is posterior. And that's the same technical problem we face in a 2D angio picture. So you don't know which one of these vessels are a branch of an SMA or a lumbar, unless you do another oblique shot. And that definitely, the more and more oblique angiograms you do, you add up to radiation and contrast load. And that is precisely what we try to mitigate by doing the CT. So the CT gives you that three-dimensional picture, but the key is, what is the missing link? How do we get the information from CT and have it available when we do our angiogram? So that's kind of what we'll touch upon later. And the imaging has progressed. So these are just the only complex slide I'm going to show. I know Dr. Lumsden asked me to cover only basics today. So these are just examples of how imaging has come from 2D into 3D, and now we are becoming in 4D. It's a case of type 2 endoleak, where you can see an L4 lumbar filling the sac and washing out of L3. and a type B dissection where you see an entry tear in a dynamic MR that shows the true lumen compressing and the false lumen flow coming out from the proximal entry tear. So let's jump right into the topic. I'm just going to touch upon very few basic points. Feel free to stop me, interrupt me. I'm going to review some cases and go through them. What does DICOM mean? Can anyone expand? We keep saying DICOM images, DICOM images. What do they mean? Any takers? Okay, so I'm not a cat person, but this is the picture I picked up when I looked for JPEG in Wikipedia. So the common analogy I can give is everyone is familiar with our cell phone pictures. And before the standardization of the 2D image format came in, JPEG was like Joint Photographic Expert Group. So a group of people came together and defined, okay, this is how we are going to store our 2D pictures with a particular level of compression, and that's kind of what was set as a standard. Just in the same way, DICOM images have become a standard back in 1983 when American College of Radiologists and NEMA, the standard that defines the American standards, came up with this standard. So the reason for this is every DICOM image has an embedded patient information in it. So even if you get a DICOM data 15 years, 20 years from now, you can easily link back that DICOM picture to the patient, and also you can clearly see which scanner that image came from. You can clearly see how much X-ray dose was given to the patient. All this information is buried, just like we go into our JPEG and go into the file information, it's all buried into that. And that is one of the reasons when we talk about anonymizing data sets for other research purposes, it's often very challenging because most of this information is built into the header files of these DICOM images. And this is what enables us to work on multiple vendor scanners. So you might have a Philips operating room where the patient might have a CT from a GE or a Siemens or a Toshiba scanner. What enables us is because we have a common standard. And currently, we don't have such a standard for video recordings, for example, in surgical cases. So these are some of the areas where there is still a lot of improvement. Most of what you see in the operating room is documented as an MP4 or a picture, which doesn't often get into PACS, and you're relying on what a surgical note is based on what a fellow or a surgeon dictated at the end of the case. So we're going to touch on 4, possibly if we have time, 5 main topics. I'm going to touch a little bit on how CT images are created, and we talk a little bit about CT Hounsfield units and multiplanar views. If there is one thing I want you to learn from today, it's multiplanar reconstruction. I want everyone in this room to transition or graduate today from looking at CT images in axials to how do we do that in multiplanar views, and hopefully I can convince you to why we should do that. And then talk about some complex 3D volume rendering technique and how we can use it for even open/endovascular planning. That's why I kept it as 3D interventional planning. So this is the inside of a CT gantry. I'm going to pause here before it gets faster. Can anyone here identify where the X-ray tubes are in this picture? Which one is an X-ray tube? Is this an X-ray tube or is this an X-ray tube? Or is this one or is this one? Oh, maybe I should use my. So 1, 2, 3, 4.
1 and 2.
Okay, 1 and 2 are, so this is a dual energy CT scanner. So you have 2 X-ray tubes, 2 detectors, and you can see how fast it spins. So right now it is just starting to acquire. At the peak speed, you can see how quick the acquisition is. So the reason I'm showing this is how powerful the scanner is, and we are really not making use of the maximum potential of the CT scanner, especially when we are talking about peripheral vascular disease or any dynamic disease process where we are injecting 80 cc's of contrast, but we are just taking one picture and making our entire diagnosis based off of that one picture. that we are looking at. And that's kind of what I wanted to allude to towards the end. And one of the technical advancements that made this possible, when you have an X-ray tube and the detector spin this fast, somehow the electrical connection has to happen. And that was the big breakthrough moment in the CT scanner, is what we call as slip rings. So you have this non-physical contact points. So even though the gantry is spinning so fast, there is this connection between the X-ray tube and the detector electronics to the gantry through this contact brushes that are not really physical using the slip ring technology. That's what has enabled CT scanners to go from like 2-slice CT scanners to 320-slice CT scanners that we currently have. I think we probably have touched on, in the interest of basics, so in CT scanner, most of our image acquisition is done in the axial plane. So as the patient is advanced in the table, so most of the acquisition happens in axial plane. Unlike in MRI, you can acquire data in any planes you want, coronal, sagittal, or even oblique planes that you want in MRI. In CT, you always acquire in axial, and you reconstruct the data in coronal and sagittal views. And that's one of the reasons why we often ask for a thin cut slice. We'll come back to that in a second. This is the only kind of equation I have in my entire slide. Bear with me, I'll walk you through this. So this is important for us to understand the Hounsfield unit. We often think, oh, Hounsfield unit, we know the number. But I want you to understand why that number is there and how we derive that number. Let's think of this, let's ignore this equation for now. Let's think of the X-ray tube that we saw in the previous slides. So let's say the X-ray tube is sending out 100 photons to the body. And here in the detector element, you are capturing only, say, 60 photons. And you know the 40 photons have really been what we call as attenuated, but you can say that the 40 photons have been absorbed by the body, right? And that can vary depending on what tissue that you are looking at. For example, if you have air in the stomach, for example, here, that's not going to absorb a lot of photons. Whereas, for example, a rib here, or in this particular case, if there was a spine here, then that's going to absorb more photons. So what the absorption coefficient is what is called as attenuation coefficient, is probably what you are seeing as this mu, which is the attenuation coefficient for individual tissues. So I'll come back to this in a second. So think of this as a 2x2 cube, right? So you know these values, how much you have attenuated from all possible projections, because the tube and the detector were rotating around the patient. So once you get from all possible angles, you'll have essentially a matrix with numbers filled in. Right? So you know the summation from A to D is 7, you know summation from B to D is 10, B and C is like 11. So once you have these numbers, which is kind of what we are getting in our detector, you can solve for this individual digits. This is what is happening in image reconstruction. So if you read that book, they call it, there are two ways of doing it. It's called filtered back projection or iterative reconstruction. But essentially, we are solving for each one of these point in this image and how much it is absorbing the X-ray radiation or photon is what we are calculating. And why is that important? So the reason for that is we have to have some way of standardizing. If I go and get a CT here in Houston, and then if I go somewhere in Taiwan and get a CT, the value that we are measuring in our, say, liver, for example, even in a non-contrast scan, has to match across vendors, across time points. And that can only happen because we are, just like we are normalizing in most photography to maybe a sky pixel or a black pixel is often taken as for normalization. So we take water value. So you kind of take, the CT scans are often calibrated by having a water phantom, and you do a CT scan, and that water value is what is used for calculating or normalizing this CT number. And this is exactly what we derive as CT number. It's multiplied by 1,000 to make not a decimal number, more as a number that is more used in practice. So this is what is defined as Hounsfield unit values. And that is one of the reasons why, if you look at the CT scale, the water values are often 0. So water is your reference point. If water is 0, anything that attenuates X-ray photons more than water is going to be more denser than water. For example, bone. So in this particular case, I have blacked out, hopefully. So, and you can see anything air or lung tissue, it's going to be less attenuating than air. So that's why you get a negative 500. And I'll come back to this window width and level in a second when we are doing the actual scan. So these are the same image of a CT scan. We are looking at it in 4 different windows. And these are not 4 different acquisitions. You are just looking at it in 4 different window values. So you are focusing on the structure of interest. For example, if I go back, and if you focus your window width at this positive level, then you are focusing on more towards bone. If you are bringing your level to more towards the negative 500, you are looking at more lung tissue. And that's exactly what is happening here. Let's see this example. Let's look at this picture and see the Hounsfield unit value. So here, the 0 is somewhere here, and we are focusing more on the negative Hounsfield units. That's why you see all the lung parenchyma better. Whereas in this picture on the right, we are getting it more towards the positive values. That's why you see in the same picture, even without contrast, you're able to see the ascending aorta, descending aorta, pulmonary arteries, and even the muscle and the breast tissues are seen very well better. So this is what is something that you have to be absolutely clear in the concept, and when you are manipulating the CT images, you have to be paying attention to this. So why do I say that? If you go back to this picture, and if, say, for example, the patient has a thrombus in the aorta, and if you are looking at it in a window value like this, there is a chance you might miss the thrombus because this image is not really windowed for the low attenuation values that you would see here, right? So this is, or the same can happen in pulmonary embolism, for example. You might look at the image in a non-optimal window value to get there. I'm going to demonstrate that in a second, how you can read the CT images before we go to the multiplanar views. I'm quickly logging on to our PACS server. So I loaded a couple of training cases. So we are going to go through the windowing values. So this is just one DICOM viewer that we have. This is a kind of like a client-based server that is connected to most of the scanners in the hospital, even the satellite center. So this is one go-to place where, at least locally here in Houston, we go through. For example, if I go through DICOM QR, and these are all the scanners that are connected to this particular system, we can import the images here. So let's take one case example. I'm going to review all the EVAR cases, an EVAR case here. So let's go through the images, and I'll come back to these individual sequences of how to do it. So this is just a basic multiplanar view. So what you saw here, what you see in the PACS is just as axial images. This is what you see in the PACS. And when you load them into a DICOM viewer, it doesn't matter, it could be Ozarix, it could be Horos, these two images and the bottom right image are all artificially rendered. Oh. Give me 1 second. Okay, good. Now we have it. So the image on the top left panel is your axial view. The image on the right, top right, is your coronal, sagittal, and the 3D volume-rendered images. So all these three images are artificially rendered based on this raw data. So let's take one specific task. I want to focus on one vessel. So in this particular case, I'm going to focus on the celiac origin. For example, I'm seeing it in the axial view. I'm zooming in this image. right here. So this is the, I'll come to the multiplanar views. Let's just focus on the window values here, right? So here, this is your window width, and this is the center. I don't know if you read it on the bottom right. Maybe I can make it bigger. So I'm just, hopefully you can see it. So let's say if I leave the center of the window value as 0, like we talked about, and in the width, I make it 1,000.
So the center is the same window level?
Yeah. Yes. Window width and the center is same as level, right? So if you broaden the window, say for example in this case, if I go to 3,000, you see how the image has more shades of gray. I don't know why it's blinking. So compare this 3,000 width to now I have just 30. What's the big difference, right? So the narrower the width, the lower the shades of gray you are going to see. So this is almost like a binary picture. This is not a great diagnostic quality, whereas if I make it to 300, you are already seeing more soft tissue, but you don't see the wall of the aortic wall calcification. So at least from a vascular standpoint, if you ask me what is an ideal window, I would like to say is the ideal window is when I window the image, and if I see the wall calcification and the contrast separately, that is your ideal window. Why do I say that? So calcification is what? Nothing but bone, bony ossification. And if I take my pixel lens here and measure the value of the bone, if for people who cannot read it, I'm just reading it's 999. That is close to 1,000. We saw in our axis, it's more on the positive side. Whereas if you look at the contrast, it's 350. So contrast, when we are injecting, has a specific iodine concentration. Even though we inject at 300 milligrams of iodine, most of these contrasts are 300 milligrams of iodine. So that's why we ask for Omnipaque, Visipaque, whatever. It's 300, 330. So when you inject here, by the time it goes through your right side of the heart, mixes with the blood, you are diluting the contrast, and it is not going to be as dense as your bone. So when you are looking at differentiating the vessel wall and the lumen, we have to have enough width in our window to be able to account for that variation. So if I had a narrow width like 300, you are not going and a center, oops, sorry. So if I had a center at 0 and a width of 300, both the contrast and the bone have the same pixel density assigned to it, and that's why we are not seeing it better. So that's why in most of the PAC system, these are kind of like configured into your shortcuts. You see here on the bottom right, F5 is for soft tissue, F6 is for lung, and F7 is for bone. And so if I go to bone, it's for bone window. And if you go to auto presets of, say, lung, so this is optimized for lung windowing, you see here. So instead of you going and manually changing these window values, you can quickly toggle through with these quick shortcuts. So if I change the same lung window to a soft tissue window, you are seeing more of the soft tissue, you don't see any lung.
Wasn't there a preset for angio up there?
On the top bottom right? Yeah. So this is
like it's not a very good preset window. We invariably have to manually window.
Yeah.
Why don't you fix that? You work for Siemens.
So the short answer to that is, depending on what, so these are just random guesstimates based on the histogram. So basically what the algorithm is doing in the background is trying to create a histogram of all the intensities and giving you a random window. And this can vary depending on whether it is a 5-month-old baby versus an 80-year-old who might have a strong, like a highly ossified bone. And those values can vary. Even geographically, the Hounsfield units can change. And that's something we often can get you close enough, but you often have to manually window it. And that is one of the reasons I am teaching here of, before you go and randomly go left, right, up, down, there is a method to this madness, and that's kind of what I'm trying to.
Going up and down and side to side,
Yeah. For example, if I go up and down, you can see on the bottom right of the screen, it's the center that is changing. If I go left, right, it is the width that is changing. And that's kind of what I was trying to manually program to explain first. So now, with either your mouse input or your shortcut keys, you can get these windows right. Is it too basic? If you already know this, I can move on to the next one.
I'll speak for myself. It's not too basic.
Okay.
It's too basic for these guys. We need to go.
Well, I'm not a trained radiologist. I've learned all these things by myself, and I am sharing how I see this, not just from a physics standpoint, but more of how you can use this from your day-to-day image review standpoint.
You are going to be so much better than any of your attendants. Shameful. You're going to have to hold back and not be brutal because you're going to know more than anybody.
All right, can we?
The most valuable thing is Thomas, window, so that you can distinguish the wall calcification from the contrast and the lumen. And that's really what we need to know.
Yeah, and since we are talking about that, I'll take through one more example. I'm not going through the clinical review. I know there was a session on clinical review, but let's say if we review this scan from an access standpoint, I'm just going to go back to our angio window, for example, and I'm going to scroll through, maybe pick on one of you guys to just focus on the axis. Say you're going to do an EVAR. I'm going to scroll through from the bottom. This is the lowest most slice. I'm going to scroll through. Whoever wants to be a volunteer? Anyone?
Yes.
Choose a volunteer.
Okay. I'm sorry. Can I get your name? Dylan. Okay.
So you can really pick on them pretty bad.
Okay. I'm scrolling up, and you can tell me the axis side and see which side you are going to go through. There is a reason why I'm doing this. Okay, so we are already in the aneurysm. I'm coming down. I can go slowly if you would like. So that's the bifurcation. Okay, which side do you want to go? There are only two choices.
I think
Right? Why do you say so? Less tortuous on the right side, okay. Okay, I'm going to stop here and ask, how many of you saw the stent in the left iliac? Anyone saw the stent in the left iliac? So this is another reason why we have to do the right windowing. For example, I was kind of focusing on the calcification. So here you see the calcification and the stent both have the same attenuation values or a Hounsfield unit assignment. So now when I window this, you see it, you still see it, but it's not very clear, right? So this is where what I call as your windowing has to be right, and one view is no view, right? So you're looking at it in axial. So what I'm going to do is bring my crosshair right on top of the stent and show you in the coronal plane. So why does the image look so raggedy here? You see, even if you look at the iliac crest, the patient's iliac crest is not like this with all these stair stepping. So this is what we call as artifacts because you have missing information in these slices. So if I go back and load a thin cut CT of that same data set, you can judge by yourself. I can load it side by side as well, and then you can compare. For example, if I go back, the same CTA that we were looking at.
So that's another important point, is that the PAC systems get overloaded, so they may only store 3 or 4 millimeter slices, but they may have been acquired in 1.5 millimeter. That also is stored somewhere.
Mm-hmm.
You can actually go back and get it. So for example, you're trying to build a penetrating graft, and you want to be really accurate, you need the 1.5 millimeter slices, and they often exist, but not for your viewing.
Do they? That's the question I have. Do they always exist?
So
Or do sometimes when they store it, you actually lose
the answer is if it is stored in the hospital somewhere, it is there. But my recommendation, knowing all the variation that can happen in the individual hospital, is if you know it is a critical case, I think, here I can speak for the surgeon, it is our responsibility to request for what we want. We don't want to get what was acquired. We don't want to just get the images of what the radiologists want in terms of for their reading purpose. So for them, it doesn't matter if it is a 2 millimeter cut or 1 millimeter cut, it's not going to change their reading. But if it is a 2 millimeter cut versus a 5 millimeter cut or a 1 millimeter cut, it matters to us if we miss an accessory renal or if we miss a small, a dissection, for example. So most often, if we request for it, they can send that to PACS. And nowadays, with all these PACS systems with terabytes of data, we can afford to store this. Maybe not in all our cases, but at least in cases where we think it is important to have it. So this is just the difference. So I don't know if you can see the numbers. The CT that we were looking so far is only 169 slice. So this is the thin cut CT with 631 images. Both acquired with same contrast dose, same radiation, no extra radiation, no contrast. I'm going to load them side by side so you can see the difference yourself. And we'll look at it in axial view first, and then we'll go through multiplanar views.
Now, aren't these scans stored for a while, like on the machine,
Mm-hmm.
and then they get dumped somewhere,
Yeah.
either days or weeks later, they get kind of dumped into the PACS? Is it sort of every day that they typically?
So it depends on how busy your local CT scanner is. Say, for example, you're seeing a patient in a clinic, you sent a patient to a CT today, and you want to make sure that somebody in your team has access to that thin cut slice. If they go to the scanner room, or if they have one of their technologists send that data to PACS, then you have it. Yeah. So usually it stays there for 2 or 3 days.
Yeah, so that high slice data is there, but it can be lost. If they go ahead and send it, what's on the machine is high resolution typically. It's in there, but they can lose it because once they send it over, and that's, again, I think it depends on the institution, but there have been places where I've worked where if you were more than a few days late asking for it, they could have already sent it as 2 millimeter slices and it was gone. You couldn't get back to that original data.
So now we are looking at the same axis coming down. This is the thin cut CT. And here you see the difference, right? So not just in axial. For example, here is your stent and the calcification. Now I can bring my crosshair to that stent and show you the coronal image, for example. So you see the stent, right? So you're not seeing the entire stent in the same plane. I'm scrolling through, and this is what I call as multiplanar reconstruction. So the same way, maybe I should keep the layout consistent. Bear with me. Okay, so what you're seeing on the right is our old thin cuts, the thicker slices. What you're seeing on the left is the thin cut slices that we loaded. So what I'm trying to do is trying to align the stent in one single plane. So which is kind of what, if you look at it, here, right? So this is what we call as multiplanar views. I'll explain that in a second, but what I wanted to show you is, so now, because we have this high resolution scan, compare the image on the top left window to this pink window that you're seeing here, right? It's the same data set. Because you have the thin cut CT, you're able to resolve that stent better. So there are two things that are different here. One, you have much better spatial resolution because you have more data along the z-axis, and which is not there in this thin cut, in this thicker slice CT. This is very important when it comes to manufacturing custom-made devices like ZFen or when you're looking for evaluating accessory renals or IMA or lumbars, all the information you have much better information you have in this thin-cut CT. So while I'm here, I'm going to talk about one more concept, which so far we have moved from axial to multiplanar reconstructions, and now I'm talking about one more concept, which I call as maximum intensity projection. We saw that in one of our quizzes. So what does that mean? So right now, you are looking at the raw data at 0.6 millimeter resolution. So how do I know it is 0.6? When you scroll through, even in your packs, if you scroll through, here is your SP is your slice position. It changes from 42.3 to 43.1, right? So it's less than a millimeter, so it's sub-millimeter cut. And this is kind of how you know how much resolution data you're looking at. So what I'm trying to do is show you what I call as MIP thin. What does that mean? Instead of looking at 1 millimeter slice, right now all I'm doing is changing that slice thickness from 1 millimeter. So as I am changing it, so this is the same stent in the left iliac. So now, as I increase the slice thickness and the window, you see the stent. Does anyone want to guess what stent it is? Yeah. So when you're looking at a CT scan, say you're taking a patient to the OR, you want to know what stent was in there. Say it was not in the report. This is, to me, is one of the most important things you can take out of the CT scanner. In addition to understanding the entire angiovasculature, you can really optimize your CT scan for that particular device to really understand what you're looking at. So this explains, this same technique can be applied for branched endographs or fenestrated endographs, where you are looking at where the fenestration markers are with respect to the renal arteries, or accessory renal. So is everyone clear with this? Do you want me to go over one more time? Go ahead, please. So the 2 or 3 software options I gave you, say if you have a Mac, Ozarix, $0 software can do this. So if you don't have a Mac, the Radiant viewer, if you don't have a Mac, you have to buy a Mac. No, that's what Dr. Lunston told me. I was not a Mac person, so he kept sending me Keynote files every single time when I started working with him. I eventually got to a point where I had to go and buy a Mac.
So, but I'm going to play dumb, because I am. So maximum intensity projection as opposed to minimum intensity projection. So what's the maximum intensity part?
Okay.
Stacking the image.
So what it is doing is, if I give you an example, let me start this. So for example, if I change the same, maybe I should go towards the, so we have some part of the lung here. So we looked at in our Hounsfield unit scale, air is, wow, very good. Thank you. So say we want to see the bronchial tree, right? We want to make sure that our window value is in the -1000, but instead you can also do what I call as minimum intensity projection. So right now I'm doing the same way I did for the stent. I'm adding the slice thickness, and there you go. So now we have the bronchial tree. So this is an abdominal pelvis scan, so it doesn't have the entire chest. But here you see the airway is more pronounced when I do a minimum intensity projection. So what it is trying to do is, so whatever thickness I give you, 10 millimeter, wherever my current slice position is, it goes back 5 millimeter, goes forward 5 millimeter, and shows you only the lowest pixel in this slice. And that is what you are seeing as airway. And if I did the same thing, the same concept I did was, say if I did the same thing in the aneurysm neck, for example, at the level of renal, I'm doing a MIP thin, for example, and I'm making the slice thickness to 10 or 15 in this particular case. And now you're seeing the entire aortic neck from this slice, 7.5 centimeters behind, 7.5 centimeters in the front. It averages and shows you the maximum intensity pixel. That is one of the reasons you are seeing all these calcifications in the neck. This is, in my mind, a quickest way of knowing how bad your neck is before you do an EVAR. Yes, you can, in theory, scroll through the axials and get that assessment, but I would still, you don't get that global picture when you're scrolling through the axials. For example, if I showed you the same image and showed you, a heavily calcified neck, and if I showed you this axial view and quickly skimmed through it, you might say, it's some calcified, but it's not really that bad, right? So you're visualizing what you want to see. For example, in this particular case, if I switch to minimum intensity projection and made a thicker slice, I'm not seeing any of those calcifications. But if I go back, what we are seeing, air in the colon. So this is something what I typically won't do, but if we do an infected EVAR or something, and if you wanted to see any air pockets in the aneurysm sac, this is probably the right rendering mode to do it. But we don't often use in vascular minimum intensity projection. We often use what we call as maximum intensity projection to look at calcifications, because those have highest density values, or to look at stents, which we very clearly missed when we were looking through the axial views.
And are they always setting the depth of the mid projection?
Mm-hmm.
They're always having to determine how.
Yeah, so we can custom determine. So right now, it's always with respect to the slice you are currently in. If I have a stack of bread in front of me, if I define my slice, it's like if I do a 10 millimeter slice thick MIP, it's going to do 5 millimeter in the front, 5 millimeter in the back, add that, and show you the brightest pixel in that. So now we are seeing the entire stent in the left iliac artery that was there. So the history behind this, the patient got a cath and got the stent deployed, so we deployed the EVAR device from the right side, just as you suggested. But I'm just showing you how you can use the same rendering techniques to look at. So the way I see this is, yes, do you really have to waste all this time? Just crawl through the axial, go to the OR, step on the fluoro, and you will see the stent. But is it better to prepare upfront to know what stent it is and where it is and the extent of it is, or find that out in the OR? The way the concept I'm trying to pitch here is, it is your responsibility to make sure you extract as much information as you can from the CT to plan for your procedure. Nobody is going to do this for you. You have to do it. And you have the tools that are out there that can do it for you, but unfortunately, I don't know how much it is nowadays in the vascular curriculum that these kind of imaging basics are covered. And this is one of the reasons I wanted to really kind of touch this topic. We are hitting 1 o'clock. I have covered maybe half of my slides. But I'll touch upon a few more things, and then we'll go to read a few more cases. So we covered the first two topics. We even touched the MPR. I'll cover the MPR from an EVAR context in a little bit. So what we are talking about here is, if you're looking at a JPEG image, we are talking about 10 megapixel camera, 15 megapixel camera. That's your resolution of your image in a 2D plane. So the same concept when applied to a 3D volume, like an MRI or a CT volume, it is called 3D voxel. It's called volume element, that's why it's called voxel. Pixel element is called pixel. And when you have thicker slices, what is happening is you don't have what we call as an isotropic voxel. So the reason you need an isotropic voxel is all this rendering requires you to have a symmetric object. And if your object is asymmetric, or if your voxel is asymmetric, then your lighting and the rendering becomes thrown off. And that's what we saw in our own example with the stent. And this is just a screenshot. This is not a Mac. This is just a screenshot to show how you can angulate your axis. So this is what in Horus, if you load your data set and if you go to 3D multiplanar view, you can align your axis along the multiplanar views to get it. I'll cover the multiplanar views in a second before I go through this. And then we talked about axis planning. So when it comes to axis, we want to make sure we study this particular segment of the femoral artery right in front of the femoral head. So in case when we are closing, we can apply pressure, and we are staying away from this branch. Which branch is this? Anybody? And which vessel is this? I'm sorry? Inferior epigastric. So we wanted to make sure we see these two branches and find an optimal angle that opens this up, or like kind of know the depth when we have the inferior epigastric artery as well. So we're going to kind of move from multiplanar views into some volume rendering. So I'm going to talk about bone removal and volume rendering techniques and how you can use this for two main purposes, even before you go through any fancy fusion imaging. One is, how do you plan your incision, whether it is open aortic or your carotid procedure or you do your venous bypass, whatever you do, you can get that context of where the deeper structures are with respect to the skin incision and how we can optimize your CM angle. So if you wanted to get so we all kind of study imaging in axial views, but we are not really trained in kind of getting the sense of where these structures are in three-dimensional structures. So one resource I often find useful is you can go into these kind of digital atlases online and kind of get an understanding. Just play around with it, see the relationship of aorta to pulmonary arteries, or the left atrial appendage, or the ascending aorta to the PA. You really get a sense of how things are oriented in 3D, so that way when you go to your angiography, you bring that three-dimensional orientation in your mind when you're reading the angiography. There are plenty of such atlases available online. You can even render your CT data sets and get that information, but if you want to get some basic information. So we're going to touch briefly on EVAR and kind of call it a session, and I know we are already hitting 1 o'clock. So I'm going to go through how you better measure diameters, how to get lengths, and this is kind of the tip sheet that we usually have for all our aortic or EVAR cases. The angulation, the LARAO craniocaudal angle for the right renal, left renal, celiac, SMA, and both hypos. And once you have this information, you can get all this information from the CT scan even before you start your case. It could be 5 o'clock in the morning or 6 o'clock in the morning or the evening before. And this is probably what I would say the best tip sheet you can carry with you before you scrub in for the case. So you know what angle to exactly go to before you do your angiogram. So gone are, at least I would like to see when you become attending, gone are those days where you do an angiogram, that looks like a crappy angle, let's just go a little bit more oblique and do another angiogram. And we have just wasted another 20 cc's of contrast while you have all that information buried in your CT scan. Let's switch back to our session. Any questions while I'm loading the DICOM viewer in a sec? So we're going to take that high-resolution CT that we just had, thin cuts. So and what we call, so right now I'm going through some dedicated applications. You can do the same thing with Ozarix or Horus as well, but here it'll make your life easier. So I'm just opening with a workflow called CT Vascular. So what it does while it is loading, I can explain, is the algorithm is trained to look for known anatomical landmarks. So in this particular case, it's an abdominal pelvis scan. So it's going to look for pelvic tuberosities or anterior superior iliac spines and spine. It will find every structure and it automatically, you can see it's processing and it'll automatically remove the bones. And also right now it has computed the center lines. So if I go this is not pre-computed data, it just computed real time as I was loading this. So it automatically computed the center lines of the aorta, so the left runoff and the right runoff. And if I go to the renal artery, so it automatically, maybe I'll make it bigger. So if I go to the right renal and the left renal, so it automatically identified this, and it removed the bone as well. And you now you can kind of get a sense of the landing zone of your EVAR and your axis site as well. And so that's your hypo, and here is your, let me bring back the bone to get the bony context. So if you do it in AP, so let me remove this. Okay. So here, you say you're gaining access here. You already know we are above the profunda, and there is also a smaller branch here. So, and you kind of know where the calcifications are in this particular artery. So this is what we kind of gives you a global picture of where the calcifications are, and this is a 3D volume rendered image. And let's go back to the EVAR planning. For example, we want to go and plan for an EVAR device. So what we have typically access to in PACS is these axial images. So time in and day out, I see this done on a daily basis. So you see the renal, we come back down a little bit, and we measure here. Okay, so here is our aortic diameter. How many of you have done this? Okay, so, and especially if you are getting a rough estimate of where the neck is, this is a good technique. But what I wanted to show you is the slice that we are measuring here. So if I bring back my cursor, so let's go back here. So the slice we are measuring here. So these windows are color-coded for a reason. You see the bottom left window is orange outlined. So what you are seeing here is right where this orange line is. So when we measure the axial diameters in this particular plane, we are not really measuring the aortic diameter, like true aortic diameter. We are measuring where this orange line is cutting through. Do you see what I mean? So this is one of the most common reasons why we get errors when it comes to sizing, and this can translate to type 1A endoleaks, is because most often people don't do these 3D multiplanar renderings. You look at the images in axial views in the PACS, you measure it, and then sometimes I see even the reps counting the slice position and say, okay, it starts at 100 and the hypo comes off at 170. Let's take a 7 centimeter device and a 20, say 20, if you see 27, say 29 device, and we go ahead and do the case. You can get around this if you are doing this in a straightforward EVAR case with long necks. But if you are going into this juxtarenal aneurysm doing fenestrated EVARs, there are no shortcuts we can take. So the true ideal way of measuring is, as you can see, the aorta is taking a posterior bend here. So we want to be able to make sure we are aligning our cursors right parallel to the center line of the vessel. So for example, this is our first oblique view that we have created. The second oblique view, as you can see in this particular plane, the aorta takes a turn towards 11 o'clock. So this is our second oblique view where I'm aligning the orange plane as though you are cutting the aorta right below the renal. So for example, if you want to be really precise, just below the right renal and the left renal. So this, what I'm just demonstrating you is what in radiological term is double oblique. Why is it double oblique? You did the first oblique by aligning for the anteroposterior bend. The second oblique is you're aligning for the left-right bend of the aorta. And now what you are seeing here is the true orthogonal diameter measurement of the aorta. And this is probably the best way to measure the diameters and even lengths for your EVAR. So we get 21.5 and 21.8 as compared to our previous measurements that you are seeing here. We got 27 and 23. So you see that difference in the measurements. Anyone not sold on this technique?
Yeah, so why is that better? It's not better than measuring diameters off a centerline reconstruction, right? It'll do the same thing.
Yes.
So if you have a centerline that's corrected properly, you've looked at it, that's also giving you orthogonal views.
Yeah.
At each point along that center line.
So I'll show that here. I'll explain why. So for example,
Essentially, that's the center line at one plane as opposed to all up and down the vessel.
for some reason thinking there is a two monitor, so that's why the center lines are coming on the other view. Okay, there you go. Now you have the center line. So now I'm going through the so now we are measuring. So this is the center line that it's automatically corrected. So now we are looking at the double oblique view based off of the center line. And here, if I make this image, so this is automatically computed center line based, truly coaxial views. So this is, so my disclaimer, Dr. Ait, you asked the right question. What do I believe? The accuracy of this method relies on the accuracy of the center line. And that is dependent on how well these algorithms are trained. A classic example where I often like to, this is kind of like driving an automatic car versus manual car. I always would like to teach people how to do it manually first. So the reason being is, say, in a dissected aorta, you often see the center line kind of going from true lumen to the false lumen. And if your center line is wrong, your true orthogonal views can be wrong. But it's often, so if you have automated tools, there is no harm in using it. But before you go ahead and believe the measurements, make sure your center lines are accurate. How do we make sure? Just like as I did here, you scroll along the center lines and make sure it's running along the center line of the aorta. Or you can go back to your 3D volume rendered views. And so if I go back here, you see my center line, right? So it's clearly within the aorta. If it was dissection or anything, and for sometimes, if you don't have high resolution data, it can bleed into nearby vessels, or sometimes it can bow into the aneurysm and things like that. So I often this is probably the most important thing that I would like you to walk out of this lecture. If you are done with this, I think I can go home and sleep that I've taught you something. Any questions? I think we are running a little tight on time, 1:15. You can do it in Windows, but the softwares are not as good as Horus, I would say. But I am pretty sure your hospital has access to these multiplanar views. And more PACS systems now have 3D multiplanar reconstruction capabilities. And now there are even web-based DICOM viewers that are coming up. So, I mean, in a few years, I see this to be available in most PACS systems. And there is no reason or justification not to learn this. All right? Thank you, guys. I'm sorry? We can run the same 10 questions again to see how we all perform and see who is the topper. Let's see.
You're never going to get this again unless you're down here. There's nobody like this in America that can teach this in a way that those of us who have no knowledge can understand it, and it's really remarkable. You just do a really good job at this. You're a really great resource. Thank you for doing it.
Oh, thank you. Happy to share. All right, good to go. Let's start. And I get this question all the time from people, oh, do I really have to have a Mac? What can I do with Windows? If you go to your local hospital, if you don't have resources, if you run into any issues, you can definitely reach out, and I'm happy to help on an individual basis because this is such an important skill to have. Let's see who is the topper this time. 19. Zaza. All right, I'm gonna hit start when we hit 30. Nope, 25. Okay, I'm gonna hit start. It's okay. All right, I hope everyone gets this right. Oh, this is Hounsfield, by the way, in case you were wondering who it is. Oh, please. Okay, I'll come back next year. I thought I clicked next. Okay, next one. WW. So in case, if you already answered here, you can see in the picture, in the lung window, you see the window level is at negative, and you can see most often the width, more than width, it's the level or the center of your window matters. Oh no. Okay. Let's try. Okay, somebody's just messing around here. Or maybe somebody here doesn't like me. So the same concept applies to MRI as well. So if you are familiar with this, you can do the same with MRI. Next. Okay, please everybody get this right. Oh no. Okay, Marvin's doing good. We didn't really touch much on MRI, but so compared to nitinol, stainless steel creates these huge signal voids in MRI, and that's one of the reasons, say, we even take patients after TEVAR, after type B dissections. So the first thing is to know which type of stent the patient has, and that's one of the reasons I created this question. All right, smaller vasculature, renals, lumbars. Okay, that's good. Majority got it right. Marvin is still on the lead. So the following rendering mode is for visualizing air, for example, tracheobronchial tree. I should shuffle it.
Oh, yeah, you shuffle these and the whole thing.
Okay, good. We have 2 more, and then we can go on to the hands-on stuff. Okay, we talked about contrast agent. So even in patients with renal failure, we try to do MRI if we can with ion-based contrast agent. So this is absorbed by reticuloendothelial system, not through renal. Oh, wow. Somebody really hates CT. Thank you, Marvin. All right, let's see if somebody overtakes Marvin. So the answer is the Earth's magnetic field. If you measure it in Tesla, it's in really like very small value. It's in millitesla. So you can, the reason I created this is so you can get a sense of how strong our magnetic field in the MRI scanners are when compared to Earth's magnetic field. And the other questions explain why you get these noise when you get an MR is because your gradient coil around the patient often vibrates. That's kind of why you get the signal during the MRI. So, who is BM? Great. Ta-da. Marvin. Where is Marvin? All right, thank you guys. Hopefully you learned something new, and we'll see you back.
Thank you, Panraj. Congratulations, Marvin, Matt. We are going to head outside to take a group photo. I have staff outside that's going to help kind of guide you guys to where we're going to take our photo. It should take about 10 to 15 minutes, and then we'll head up to the lab.